So I promised you that this wasn't all going to be theory, and it wasn't all going to be based upon what's happening around other parts of the country. I promised you that I would bring you some neighbouring practices to come and talk. And I'm delighted now to welcome Dr. Nina Pearson and Heidi Newton from Leval Medical Practice down in Luton, where they have been doing some fantastic work which has really impacted immediately on the stresses and strains of their practice. I'm going to leave it to Nina and Heidi. Thank you very much.
Thank you, Peter. For those who don't know us, we're a Leval Medical Group in Luton. So we are a 24,000 patient list practice over 3 sites, so we're serving that central Luton band. Our population is probably slightly younger than most of our colleagues, probably in Hertfordshire and in North of Bedfordshire. We find that our population peak is between 0 and 35. 42% of our population do not have English as the first language, and we have a real transient population, so they're actually accessing healthcare in the NHS for the first time, and that brings a lot of challenges on how we actually manage patient behaviour. 2 years ago, we realised we needed to change. We were using a traditional method of general practice for our doctors to see their patients. It was face-to-face sessions, 18 appointments in the morning, 20 appointments in the afternoon, home visits in the middle of the day, and cramming that paperwork and prescriptions in when they could. We couldn't meet our demand, so we changed to a telephone triage model for our same-day demand. So we were running 2 different systems. We had routine appointments where patients would come in, book, sometimes up to a month in advance, and then if you were classed as an emergency, and that's a lot of patient expectation of what is an emergency to be seen on the day, you would receive a telephone call from the GP. That telephone call used to usually result in them being brought back into the practice. But our routine GPs, our salary GPs and partners, were already seeing a routine list. So where did we bring those patients back? So we started employing locums. So we're all bringing patients back in to see a locum for a reason that another GP had triaged. We'd lost continuity of care. We had locum costs spiralling. We had actually lost what our ethics would be, that we should manage our complexity of our patients in-house and stop pushing them out into hospital, into community. So we decided we had to change. And we looked at it, as we were talking earlier, that we are businesses. We have a multi-million-pound turnover. We have to work like a business. We used a 6-month project plan to actually start to think away how we could innovate. And we looked at different models that were being used across the country, because one model does not fit each practice. We are all individual businesses. So as I said, we had a long waiting time for routine GP appointments. Our patients would call up, and I don't know how they know this, they're psychic, the day the appointments were released, 6 weeks in advance. They would book an appointment just in case they needed that appointment in 6 weeks' time, which meant our DNA rates were through the roof. We then had patients complain they couldn't book an appointment in case they needed one. The situation was bizarre. Sometimes we saw that the patient who was so desperate to see that routine GP appointment were booking in for an ECG. We could have done an ECG the next day, but they'd waited 6 weeks. So we hadn't got our list right. Our doctors had little continuity of care. If they were wanting to bring a patient back, they didn't have the slots. There was no way that they could bring a patient back in review. The only way they could do that is to actually put extras on the end of their list, or again, have them see via locum, where you lose the continuity of care. Our same-day demand was escalating. We were not asking patients what the condition was. We were just trying to feed the demand. We got so obsessed of, we have to manage everything that's coming our way, that we forgot that we were not managing it correctly. We also had the issue that I know a lot of practice locally have had. We had 4 partners exiting over 2 years. And these are partners that have been in the practice 20, 30 years. It was a huge cultural shift for the practice to be able to move forward. As I said, our locum spend had increased. We were a PMS practice and we were switching to GMS. And those finances suddenly sharpened the mind that you need to change. And our workforce was under so much stress. Can you imagine what it was like for a receptionist, day after day, saying to patients, I don't have an appointment. I don't have an appointment. We were lucky we've been able to maintain our workforce, but it was so stressful for them all. And we knew if we could work smarter to manage our long-term condition patients, we could probably decrease some of the demand in primary care and ultimately stop them bouncing into hospital on an emergency admission. So what we decided to do is that we looked at the practice as a whole. I said we'd tinkered with our appointment system before, we tinkered with how the receptionists were dealing with the calls, and back office-wise, we looked at innovative ways of working. But we had to look at this as a whole business model. If we didn't change, we would not survive and we could not thrive to start looking at the new innovations that were going on in primary care. So we changed the doctor session. We introduced a duty role. We looked at our staff skill mix. We employed a practice pharmacist. We also looked at access on how those patients were actually accessing the appointments, so we didn't have them trying to book them 6 weeks in advance just in case. We looked at our back office role. What could they do more that could take the burden away from the GPs? We employed an emergency care practitioner. And even in this state of flux, we increased our training contingent so we could get the youngsters through the practice. We now take FY2s, we take STs, medical students, and we're looking at taking physicians' assistants in their training placements. And we changed the way we managed our long-term conditions. We invested in a template system for System 1, which allows us to actually manage our long-term conditions, starting with healthcare assistants, then building up to nurses, and then using a GP as a virtual review. So the crux of our system is we manage what comes into the practice on the day. So this means that when a patient rings the practice, they can't book a routine appointment for 2 weeks' time. There is no facility for a patient to book a routine appointment with our GPs. They can with a practice nurse, they can in the specialist clinics and the HCAs, but GP is managing that demand on the day. The list for a GP now has pre-booked appointments. These are the patients that they need to bring in for a review. And those appointments can be as long as an hour, they can be as 10 minutes. The GP has the flexibility to choose how long they need to review that appointment. If they've got a complexity that they know they can manage in one face-to-face session, but a longer face-to-face session, they have that flexibility to manage it. We wanted the receptionists to optimise the patient journey, to make every contact count. As I said, patients used to ring up, I need a routine appointment. Yes, here's one in 6 weeks' time. We never asked why. We now ask why. Some patients don't tell us. We also ask what they've tried. Have they tried over-the-counter medication? Have they been to their pharmacist? If they're in other community services, have they spoken to the community matron? Have they seen their district nurse? This information gives a bigger picture to the clinician when they make that telephone call. We changed the skill mix in the practice, so we got an emergency care practitioner. Because of our young population, we had quite a lot of children who were coming in with the viral illnesses, fevers, rashes, spots. We realised because a lot of the families in Luton do not have that grandparent support that we probably did when we were raising our children, that they didn't know what to do, so the first stop was to the GP. Our emergency care practitioner is paediatric trained, so anybody under 2 comes straight in to see him. He also provides education to the patients about where they can go to help, where they can access NHS choices, what self-care they can do for their children. And when a temperature is a temperature you need to worry about and a temperature is not a temperature you need to worry about. We then employed a clinical pharmacist. We have a high prevalence of diabetes, and we employed an independent clinical pharmacist who can prescribe for diabetes, who now runs our diabetic clinics. So these are patients who are on insulin, who need titrating or even starting insulin in the community. And that workload goes to her. She's also a support to the GPs when we get those complex hospital letters where we can't quite understand why a medication's been stopped, why is it being started, are we able to even prescribe it in primary care. She takes that burden away from the GPs and she sorts that out. We retrained our back office staff to work to protocols to reduce paperwork. So now 70% of the paperwork doesn't go to the GP. It's protocol based. Back office work to that, they will book the appointments, they will order the bloods, they will do the follow-ups. They file all our normal pathology results. They activate our bowel screening programme, our cervical smear programme. There are protocols in place, so we are safety netting them at every point. And we brought back continuity of care for patients. Our patients sometimes would come in, they'd have an appointment with one GP who would order a blood test. That blood test would be read by another GP who would then say, actually, you need to come into the surgery. Then that person would then come in to see another GP. So there had been 3 interactions, but actually nobody knew why those tests had been ordered in the first place. So we tried to bring it back, and patients are registered to a GP. If that GP is not in the surgery that day when they call, they will be asked to call back the next day or when that next available session is. And it does seem to work. Patients want to change GPs because they have a relationship problem, they're able to. So we do change them around. The duty admin role, I think, has been the most successful role that we've had. This year, because we've only been running this system a year, it actually took away 4,500 contacts, which we would normally have put on our duty list. So these are hospital consultants who are ringing up, finding out if we've done bloods. It is the district nurses who need to have a prescription or an antibiotic prescribed. It is the patient who wants to know whether their referral has happened, whether MSK are going to see me this month. They are all the things that the doctor needs to happen before they actually see the patient. So they might need to know where that X-ray result is, where the scan is. The duty admin role's sole role is to manage that non-clinical contact. And we have one person doing that each day throughout the time that we're open. As I said, we introduced new long-term conditions clinics, and we found this has put a real enthusiasm into our healthcare assistance team because they're now managing a caseload. They're not just seeing phlebotomy and dressings. They're looking at the long-term conditions clinics. They do the pre-assessment. They do the bloods, the questionnaires, the measurements. They then go on to see a practice nurse who has a speciality. So all the patients who require a GP appointment speak with the GP on the phone first. Some patients don't like it. Some patients still want to see the GP face-to-face. But when we explain why we're doing it and how we're doing it, it kind of allays those kind of risks that they see. GPs manage their own list with the flexibility of managing their own appointment system. I know, Nina, you went out and did a MDT meeting in somebody's home a couple of weeks ago. So we were able to block out half of Nina's morning session to actually go to the patient's home to have that MDT meeting in the home. We would never have been able to have that flexibility a year ago because we would simply have been booked up 6 weeks in advance. And our belief is that everyone should work at the top of the skill set. The GP should be there to look at the complex cases, should be doing the care planning, should be going to those MDT meetings, managing the palliative patients, making sure they've got that support in the home on that difficult end-of-life period. We have minor illness nurses, practice nurses, HCAs who can do the acutes, who can manage the long-term conditions. We need to let GPs be GPs and not do this minor illness demand. So how we changed. The key for us was engagement, and I really can't emphasise enough that as practice managers, we are the leaders in the practice. We work along our GPs and we design the clinical model, but it is up to us to deliver, to innovate, and to direct how these services are changed. If we don't believe in what the model is going to deliver, and there's any negativity from us, it will feed down onto the staff. Even if we want to go and lock ourselves in a dark room and cry because it's all gone horribly wrong, we actually have to be positive on that model that we're doing. So when it came to engagements, we did engagements with patients for our PRG. We did engagement with our staff, but very soft engagement to begin with. This is the model. How do you think it will work? We were then able to tease out any negative thoughts they have, any positives, any ways that we could change. We then drilled further. So we had a 6-month project plan. So we then looked at team-based training. So we worked with the different teams, the receptionist, the admin, the HCAs, the nursing team. And then from that, we were able to identify maybe some people who were struggling with the new system, and also to bring aboard the people who were really at the forefront of innovation, the ones who had already had the good ideas. Why don't we follow the normal results? Bring them in and get the whole practice working as a team. We found, because we were all so vision to what we were doing, the doctors were spending most of their time behind a closed door seeing a patient. The back office had their heads down looking at the paperwork. We were running around trying to make sure there was appointments to meet our same day demand. We were not a team anymore. We were working in silos. So we provided training and support, and I said it was group training, one-to-one support. Look at the needs of your practice, see what they actually need. And then we provided flexibility because we were able to give an HCA longer appointments to do stuff. So they didn't feel that they were continuously just seeing a patient every 10 minutes, every 10 minutes, every 10 minutes. We had the ability to block out time for training, for online training, and it just let us breathe. Obviously, we changed our skill mix, and that is still ongoing. And I think the most important thing about when you change a system, in whichever model you adapt, is not to think that you make the change in May 2016, and that change has happened. That change evolves through the whole lifespan of the practice. And if you don't change quickly, that's when things can fall down. When we're at equilibrium, can't say that today, our system works really well, and by Friday afternoon, we run out of patients, which is a weird concept. When it falls down, if we have sickness or we have somebody off, it is a struggle to get ourselves back on track. But we have to do that each day so we can continue the system working in the future. We've also made an investment in technology. As I said, we've brought Arden's templates that are for System 1, which not only help the clinicians enter data into a protocol format, it also allows you to bring your referrals in to a template, so it's easier for the doctors to make the referrals, but it's also brilliant for practice managers because it shows you where you're missing your income. So the challenges, it hasn't been smooth running. We decided to make the change on the first bank holiday in May last year, which in hindsight probably wasn't the best move. It was a very stressful period, but we got the whole team to believe, and we were all, as a management team, very visible. So the staff knew where we were. We were in the call centres, we were in the back office, we were on the front desk, and we continue to be so. And we now know that we need somebody in that role the whole time, so we're going to employ somebody who is kind of the advocate between the patients and the staff. We manage the list daily, so part of that duty admin role that I said about earlier, they're a traffic controller. So they know if the duty list is getting really, really full, they can move it over to a nurse who might be able to deal with the acute illness. So we're actively moving slots. They work with the duty doctor. So it's about home visits. You've suddenly got an emergency home visit coming in the afternoon, they will start controlling how that list works. And then the duty doctor feels supported, not isolated. They get a cup of tea during the day. Again, we're working as a team. We've had real problems with capacities of our telephone system. I don't think we realised that if we asked everybody to ring in on the day to book an appointment, that our phone lines were going to go through the roof. So some days we've had over 1,000 people coming through on the telephones. We've taken a new tack on how we explain it to our patients. Yes, you can wait 3 or 4 minutes on the phone to be answered, but you get seen today. Previously, your phone was answered within a minute and you get seen in 6 weeks. So bear with us while we try and make the change. But the telephone system has been one of our biggest challenges. We also have the issue of online booking. We used to offer a lot of online booking in System 1. But our message on the new system is, we choose which clinician you see because you don't need to see a doctor. It's a hybrid of a doctor first system, but in a way, think about it as doctor last. You've got a massive primary care health team supporting that GP. There are many different options for patients. Patient expectations. I want to see a doctor. Face to face, 10 minutes, I want to come to the surgery. We're slowly changing that, and it does help that our population wasn't predominantly born in the UK, so is new to our NHS system, so this is what they believe it is. But managing patient expectations is a key. Clinician behaviour as well is quite difficult because all the clinicians work differently. And there are some different behaviours where appointments may be longer or appointments may be shorter or sessions get blocked off. But we're really key on sticking to the rules. So if people start to behave outside of the norm, we're very good at saying, hang on a minute, this system's not going to work if you do that. And I think you'll take the challenges on board. We haven't solved nurse clinic DNAs. Because nurse appointments can still be booked in advance, we are still getting DNAs in our nurse clinics, and I think next year we're going to have to look at how we manage that. So, we had a lot of challenges, but we have had some successes. So if we look at the model, appointments per 1,000 patients per week, you can get we've increased from 74 to 96. We have reduced our DNAs by 48%. Now, for us, because of the size of our practice, that's 64 GP sessions we have saved. And if you want to think about the money, it's £24,000 of locum costs. So that's incredible change that we've had in our practice. Recruitment, we've recruited 6 sessional GPs. We have an issue with recruitment in Luton, we have it in Bedfordshire. Our locums, which we're now calling sessional GPs, are taking paperwork. They are managing lists. They are doing results. They like the system. We employ them on SLA contracts because they want to keep their self-employed status. We thought the IR35 guidance would help. It hasn't. But we do have regular locums. The workload in the GPs has decreased, and Nina will talk about that in a second. We've also made more investment in staff. We have clear career plans for our staff because the roles are more defined. It's not just a reception role answering that call. They are looking at signposting, looking at becoming navigators. And as our patients are very active, 72% of our 24,000 patients used the system last year. Complaints have reduced by 12%, and friends and family satisfaction has remained static at 92% in all the year. And we have increased our list size by 1,500. Performance-wise, we are still underspent on our prescribing budget, which there is always a real worry if you're doing mostly telephone consultations, your antibiotic prescribing or your prescribing will go up. We're below average on GP referrals, inpatient electives and A&E attendances. And this year, we had our highest QOF achievement to date because we have more flexibility in the system to bring those patients back. I'm going to hand over to Nina now, who's going to explain what it's like to actually work in the system as a doctor.
So as you can see, we deliberately let Heidi talk the talk for the 2/3 of this talk, really, because it's about how you do it, and practice management is absolutely essential to deliver these changes, and investing in your practice management, your admin team. So as a doctor, if you look, the column on the right-hand side is how our sketch sessions were previously. All of those appointments would have been booked, as Heidi said, 6 weeks in advance. You'd have all sorts of stuff in there that was not medical at all, somebody else's issue, or something where, you know, because I'm the gynae specialist in the practice, I got every perineum to look at that existed, and yet we got 6 other female GPs perfectly able to do that. I do the complex stuff. We're now on a left-hand side, and so as I come in to work in the morning, then I may be working a full day, maybe working half a day. I will have the first part of the morning booked, either with people that I've said I need to see because of hospital letters or, you know, planning ahead or whatever, or the nurses have seen something it needs a doctor review. So those will be booked. Maybe a couple of the telephone triages will have been taken out for another face-to-face. But I've got the rest of it booked during that morning. And it's really interesting, as Heidi said, you know, if we get all these bank holidays out of the way and get back into equilibrium, actually they're not booking until late on in the morning. People are getting contact, and then we discuss with them over the phone how to manage their problem. Can it be managed over the phone? Is it somebody else? Or do we need to direct them and bring them in? So the complex ones, the red flags, the complaints, gosh, there's a whole load of stuff going on here, I need to see you. I fetch them in by negotiation, either, you know, that morning or later that day, or occasionally it needs to be planning slightly ahead into the next session, but not very far ahead, and it's what suits the patient and their carers, and the right amount of time. So it feels now as if I give the time to the people who really need it. And I direct people to somebody else who can handle their problem. So it makes a big difference. We've saved a whole lot of appointments, and as you can see, we've you know, this has generated an extra 3,000 GP appointments by this method, and it feels under control. So our doctors all feel under control, much better than they were. It's not perfect. We've got a lot more work to do, but it feels a lot better. So that's what the day looks like. And as I say, getting the change in the workload and allowing your admin team to influence what's happening. The doctors were asked, what can you get rid of from the paperwork? We came up with about 5 suggestions. We asked the admin team and they came up with 18, and we settled on 15 in the end. So doctors are not very good at letting go, and we need to. The other bit we've decided is actually we get rid of all the stuff we don't have to do, so we're not doing the private work. Okay, and if you actually think of the cost of the locum versus what's the income from the private work, actually it's a no-brainer. And so, but what is sitting with our desk now is whatever is sitting with us absolutely has to be doctor actioned. So we get all the abnormal results, we get all the actions on the hospital letters. So you can't just, glaze over, but at least it's dealing with your skill sets. And this is what makes your doctor smile. The right-hand pile is what we receive now, paperwork. The left hand is what we would have had in a week previously. And that alone will help your teams to sit and pay attention and actually look for the next thing to change. That's all I'm going to say. We'll give you an opportunity for questions later on. Thank you.
Heidi, let's start with you.
Thank you very much, and well done to all the practices, is what I would say. My question is, both presentations came from the practices. Did you get outside help? There are commercial organisations that do, GP First, that sort of thing. There are commercial organisations that do questionnaires. Hopefully the CCG is supporting you. How much was it your own work and how much support?
The majority was our own work. We went to different conferences, which I'm sure a lot of us do, and we saw loads of different models. And there was one which is called Dr. Direct that's working in Tower Hamlets, a very similar population to Luton. And we worked closely with that practice manager to try and implement the bits that we had. We did look at Doctor First, but the financial position we're in at the practice at the moment, we just went no.
It's just we don't want to keep reinventing the wheel, do we? So how we...
I would agree, we don't want to keep reinventing the world, and learning from each other is really important. And spreading that good news. But you also asked the question, is the CCG supporting? Well, supporting I'm a CCG chair as well, but I've come here as the frontline GP today. But from a CCG point of view, yes, we're supporting practices, but actually practices know their own population, know where they're currently at, and have to be the sort of what I would say the main arbiters of actually saying yes, we want to change, and who do we connect up with, and how do we do that? But it's got to be the team owning the solution, and the solution is the team's solution. However they get the resource and the interest and the innovation from elsewhere, at the end of the day, the team implements it.
And I'd hugely support that. Yes, we had sort of, high-level support from the CCG, but it was absolutely a bottom-up approach that we took. We did get external consultancy, as I said, and what they did was they pulled our thoughts into the questionnaire that I showed you, and they wrote up the results. But other than that, the whole thing was delivered by the locality.
Hiya, I've got 2 questions, if I may. The first one was with regards to the duty admin role at Lee Vale. So can you tell me, is that a clinician doing an admin session, or is that an administrator with very high skills to be able to touch on clinical work?
Yeah, it's a administrator, and we have 3 of them to span the week, but they are what we would call our first-time managers. So they've actually worked their way up from reception roles into back office roles and patient service manager roles, and they are running that duty admin role. So they are administrative, but they have been within primary care for about 10 years, so they have quite a lot of experience.
Brilliant, thank you. And the second one was with regards to Lee Valley Health. I'm a practice based in Potters Bar, and geographically, within relatively easy distance, there are no minor injury units, urgent care centres. We've got an A&E relatively close, which means that most patients default to A&E. And we really struggle to manage the non-GP but non-A&E demand. In your experience, if you didn't have that minor injury unit relatively locally, how do you feel that your system would have been impacted by that?
Well, as I said, I think 50% of them will go to the A&E, go to their nearest A&E or the urgent care centre, or we're going to have more turning up in primary care. You know, there was, I think it was about 25% of the activity was actually primary care that they were doing. So you know, it has been a huge help, and just like Chris talked about, it's very much about systems. And you know, I'm delighted that the minor injuries unit is very supportive of our system. But it is more challenging when you, like I said, when you've got an acute that's right on your doorstep, which is a walk away. And I understand what you're saying, but just going back to what Chris was saying, we just got to bring them into the sort of system planning with that.
It's time for one last question. Thank you.
Sorry, this is a message for Heidi. With the private work, where do patients go, like for adoption medicals and DVLA? Because we always get told by patients there's no one else who can provide it.
So there are certain things that we still have to provide. DVLA is one of them. Adoption and fostering medicals, we're working with the local authority. We've actually, should it be a GP, is the GP the most appropriate person? And the rest of the stuff we have actually pushed back to private provider locally. There is one near us in Luton and there's one in Milton Keynes. And we give patients that option. And it is difficult when you've got a taxi driver standing in front of you who's saying that your livelihood depends on it, but then that's half an hour clinical time with a GP, half an hour nurse time, and numerous calls to the practice chasing it up. So we just push it back where we can.
I'm going to stop us there because we're running beautifully to time at the moment. So let's thank our speakers again. I just want to remind you it's time for a break. Tea and coffee is in the rooms upstairs if you're going upstairs. Just the people that are in here that will need to get tea and coffee from the function room.